This is a technique video for the arthroscopic bone grafting of ACL and PCL tibial and femoral tunnels as a first stage procedure. The patient was brought back to the operating room and placed in a supine position on the operating table. A bilateral knee exam was performed under anesthesia to validate the clinical exam findings. A medial incision was made over the prominence of the retained post and washer from the primary PCL reconstruction. Once isolated and the superficial tissue was resected, the post and washer were removed using a rongeur, screwdriver, and various retractors. A lateral incision was made for a parapatellar portal, and the arthroscope was inserted into the joint. A medial parapatellar portal was then made, and assessment of the suprapatellar pouch, articular surface in both medial and lateral gutters followed. Assessment of the anterior compartment is then made. A lysis of significant adhesions was performed to restore normal margins. Failure of the ACL and PCL grafts was confirmed using a probe to observe the graft laxity. Both graft locations were extensively debrided to clear the surface for bone grafting and tunnel preparation. The medial and lateral compartments were then assessed. The posterior aspect of the capsule was palpated to assess the meniscotibial and meniscofemoral attachments of the meniscocapsular junction. Both medial and lateral root insertions were assessed. The condition of the intra-articular cartilage was then observed. The femoral tunnels were assessed first to optimize intra-articular visualization and were debrided using various rafts, curettes, and shavers. The anterior cortical insertion of the tibial tunnel was identified to ensure proper tunnel trajectory. A guide pin was then drilled for the ACL and PCL tunnels intra-articularly using a tibial guide. A coker was utilized for the ACL tunnel to secure the pin for reaming. For the PCL tunnel, a large curette was placed over the pin to prevent iatrogenic posterior capsular damage. Both tunnels were then reamed to remove soft tissues in the tunnels from previous reconstructions. The tunnels were then visualized using an arthroscope to validate bleeding margins and adequate removal of scar tissue. Optiform DBM was thoroughly packed in both the femoral and tibial tunnels with assistance of a curette to firmly impact the graft and fill the debrided tunnels. Adequate margins were observed with an arthroscope to minimize excess bone graft into the joint space. The deep tissues and superficial tissues were then closed. A sterile dressing and knee immobilizer were applied in full extension.